Hi, everybody. This is Erica Mello, and welcome to episode number 130 of Tough to Treat. And my wonderful co host, Susan Clinton, and I are going to be appearing in your podcast feeds now every week. So, in addition to the episodes that you're receiving every other week, which are longer in length, and they're a deep dive into our tough to treat patients, you'll be getting another episode, which is going to be shorter, more bite-sized chunks of clinical pearls, of case studies, depends on what we want to talk about. And sometimes that's a nice way to learn on the fly, as we say, right? I do enjoy listening to longer episodes as well, but I do enjoy listening to shorter episodes. And, if I'm in the clinic or if I'm waiting for a patient or if I'm just going out for a short walk, sometimes those are good as well. So we really hope you enjoy this format. And if you have any topics you would like us to talk about, please reach out to us. The website is toughtotreat.com. And if you're not a member of our newsletter, please feel free to sign up. We've got some great clinical pearl PDFs that we would love to send you. So this first episode is on my view on taping, is how I would call this if I had to give it a title. It's everybody has views on taping, whether they tape or whether they not to tape. At the end of the day, it's nervous system input. But I have been asked over the years a lot of questions on taping. And if you have been a longtime listener of the podcast, I talk about a taping I do a lot in the foot, and that's one of my most requested videos. This taping I do in the foot, it's crazy. And I mentioned it a lot on my course, Decoding the Complex Patient. And I show you how to do that on the course as well. So this particular episode is my view on taping for all of the regions of the body, from head to toe. It's a little over 11 minutes, and I tell you what types of, I actually use Leukotape on Hypofix, so I basically tell you the types of taping techniques that I use, whether it's for supportive purposes or facilitatory purposes or just a nervous system input, right? So I think it's a tool that I use often, but I don't use it for prolonged periods, and I'll explain that in the episode. So we hope you enjoy it. Hey everybody, welcome to another clinical video, and this is on taping. And for those of you who listen to the podcast, you'll know I do tape a fair bit, primarily in the foot, but I know it's come up several times on the podcast, so I wanted just to do a quick clinical pearl video or a video on just my views on taping and what I do and what I use it for. So we're going to start from head to toe. With regards to like the neck, I will sometimes do a scapular unloading taping. So for example, if someone has some radicular pain, if they've got overactive upper traps, if they've got some just general shoulder pain, that is alleviated when I get in their armpits with permission, of course. I just have them shrug up and all of this is alleviated, whether the radicular pain is alleviated, any of their gripping strategy is better. I will do this scapular unloading taping, and what I'll do is I'll take on the ipsilateral side, I'll just take a piece of Hypofix and Leukotape, and I will once again have them shrug up, and my hand will be in their armpit, and they're in an unloaded, relaxed position, and I will literally just sort of sling the both pieces of tape up along the inferior border of the scapula in a sling, almost crossing midline. I'll go like right up to midline. And I will have the patient repeat a task that is meaningful or provocative and see if it's any better. And if it's not, I may just re-angle the tape a bit or try something else. But I've used that quite a bit and with a fair bit of success, especially with these overactive grippers in the neck, especially with overactive scalenes and upper traps. And I also use that obviously for scapular dyskinesia. I find more often than not, people who have issues with their scapular muscles, that's not their main driver, but if I need to do some repatterning in the scapula in different positions more later on in the exercise program, what I'll do is I'll tape that scapula as well in that unloaded position to see if it can restore some of the neuromuscular balance in and around the scaputhoracic thoracic joint. And in terms of the shoulder, I don't tape the shoulder very much anymore. I used to do a lot of, that stability taping and a lot of the sort of posterior glide taping. I don't do that very much anymore. What I find mostly in the shoulder are significant strength holes. And it's not so much the cuff, it's more anterior deltoid, believe it or not. You see a lot of wasting and atrophy in some of these patients who have shoulder problems, that's their symptom, or neck issues. So I don't tape it as much anymore. I know people use kinesio tape sometimes to relax the upper traps. I don't, but that certainly is another option. What I do a lot of is this upper rib taping, and I learned a lot of these taping techniques from L.J. Lee and Diane Lee when I took their Discover Physio series a long time ago. Some of these tapings I learned as well in school, and some you just sort of learn as you go, right? The patient teaches you what to do sometimes. So for the upper ribs, similar, maybe I'll use an example. If I have a patient who I believe their thorax is their driver or their source of their problem, and they're translated right, for example, right? They're translated right, rotated left. And I find that in my assessment, getting their upper ribs more balanced, so a little bit more right rotation, just to make it simple. I don't want to go too much into biomechanics here because taping is really a novel input into the system. It restores neuromuscular balance. So for the purposes of understanding, I'll use this example. So I go into, I want them to go into left translation, right rotation. So what I'll do is I may take a piece of Hypofix and leukotape and sling it up along the back following the line of the rib to restore that rotation. And I do that also fairly frequently. I generally tape one side. I don't usually tape both sides of the rib cage. When I go up into the upper ribs, I tape, because you have to go for the middle and lower ribs, you can go sort of in on the axilla to start, but in the upper ribs you can't. You have to start literally on their back, literally on like by their scapula, and tape it that way. So that's a very common taping that I do, and it's very helpful. And once again, some people can have a little reaction up in that area, so I use skin prep to prep the skin. I know Susan much uses Caladryl, so I think that's important to know. You need to sort of prep the skin. That's pretty obvious, right? I don't do it so much in the foot because the foot's pretty robust. So moving down, I don't do very much hip taping, to be honest, either. I used to do one where I had the patient put their foot in like a little bit of external rotation, puts their hip in external rotation, and I'll sort of tape up from the greater trochanter, slinging it up along the PSIS to keep their hip in more of an open position, in an externally rotated position. I very rarely do that these days, but that's one I have in my toolbox. And in terms of lumbar, the one I do the most in the lumbar spine, and once again, very rarely, unless I have a hot disc, is just a big X taping across their back, more from like lower thoracic into sacrum, to anybody who has a problem with flexion, right? I'll do that and with Hypofix and leukotape pretty strongly. And I had a patient recently who I did that with, and it helped him quite a bit because he hated to sit. And these are, once again, they're temporary strategies, or temporary fixes, I should say. And in terms of the pelvis, I do tape the pelvis, and I tape it according to the type of compression that the patient likes. And I learned this one as well with LJ and Diane. And I use it based on the compressor belt, Diane's compressor belt. So if I have a patient who likes anterior compression, if I don't have a belt handy, or if they don't have a belt, I'll take the piece of Hypofix and start at the midline, not in their back, but on their midline, and tape it anteriorly, one piece, and pretty close to the belly button for anterior compression. So that's a tape I do fairly often. That also can be a little bit sticky with the skin, so I usually suggest them to get the belt, to be honest. So that's another one I do fairly often. The knee, not as much anymore. I don't tape much of the sort of, the Jenny McConnell type, taping that we all learned years ago, lateral glide and patella unloading. I don't do that very much. I had a patient ask me last year to do the patella unloading taping, but that was the last time that I've done that. I don't find that the knee needs to get taped very much in a more of a chronic, persistent condition. What I tape the fibular head just sometimes, but once again, I don't tape the knee at all, really. But I do tape the foot quite a bit, and I do a lot of the subtalar joint taping, and I learned this in Vancouver. as well. And I literally have pick a piece of hypofix leukotape on the medial part of their subtalar joint, and I'll distract it and come up. It's one I do fairly often. I do a navicular lift quite often as well, just for some basic arch support. But the rear foot taping to gap that medial subtalar joint is something that is worth trying to get down. I tape that in sitting. They're sitting off the plinth. I'm using gravity to pull it down, to pull the tape down and to distract the medial part of the joint. And then I've been known to tape like the first ray down, the midfoot into eversion. I have several patients who can't get their big toe down. It's really common. People tend to, when their subtalar joints are not in neutral, they really put a lot of weight on the outside of their feet, and that's their strategy, and that may be fine. But for some people, when you correct that strategy, it makes them feel better. So that's why I use the taping in that part of the foot, first ray taping, as well as some midfoot taping. And honestly, you can be creative, seriously. I mean, there's no rule as to how you can tape somebody. If you're trying to train a different movement pattern, let's say into we'll use the shoulder as an example. If you're trying to tape them into a little bit more of a rotation or I don't want to even say posterior glide, so they can effectively do like a median nerve glide, you can help facilitate that with tape. You could use kinesio tape with that, and just place it across the front of the shoulder. What I've done a lot in cases like that, especially with the shoulders, I've taped the upper ribs. So you can try different taping and see what happens to their movement. That's the key. The taping's only as good as the not the technician, but as it helps the patient. If you tape somebody and they don't feel any better, I generally tell patients, leave it on. If it makes you feel worse, take it off. Don't rip it off. The typical scenario that we tell patients. But if it works, I say at least 4 days, at least, because I've had great results with taping. So, and once again, I don't really tape long term. What I'll do is I'll tape, maybe 4 or 5 visits. And then if I start to load, like heavy loading, and I find that they're losing control in their driver, the driver means the cause or the source of their problem. And in my lingo. And what I'll do is I will tape them short term, so while they're loading, so they can really get that movement pattern down. So ultimately, we're trying to train new brain maps, whether we put a piece of tape on them, whether we give them imagery, whether we cue them. There's many different ways that we can train a brain map, right? And train new movement. And it's different for everybody. There are people who absolutely hate tape. Don't want it, doesn't work, and these are people who I will tell you are super sensitive systems, super sensitive nervous systems. They have a history of multiple injuries. That's my clinical experience. They don't like tape because you're taking away their strategies. And when you tape somebody, you take away their strategies. That's the game changer. And so a lot of people who've had multiple injuries can have multiple strategies for movement. If you start taping them and taking those strategies away, they will be worse. So I think you have to use taping as part of your clinical reasoning process and as another tool in your toolbox, and you figure out, is it the right thing at the right time? I hope this helps.